My name is Jeff Livesay. I was person number 2 at MiHIN almost 7 years ago after Dr. Tim Pletcher, and ran into some interesting issues in the fall that we're going to talk about today that raised some new questions in the arena of electronic health information sharing. Some questions that we think that may not have been fully raised, at least not publicly, prior. So I'm pleased to be here with Larry Vernaglia from Foley, Lardner, and Larry's going to talk after I present a few slides. My background is 41 years in bleeding edge technology, and I started with artificial intelligence in 1977. And we're going to talk a little bit about applying artificial intelligence to real-time health information sharing. And I probably need that little remote control device there, Larry. And what are some of the ethical implications of doing that? I'll just give a little repeat, not much, of some of the opportunities of electronic health information exchange. I'll give an overview of predictive modeling. I'll talk about how we've applied AI and predictive modeling to the real-time information in our statewide network. And then I'll talk about the debug discovery from last fall. And then we'll go into the legal review of the bioethics of health information exchange. So if you were here this morning, you know that I talked about MiHIN as a network or as plumbing. The water flowing through our plumbing is protected health information, okay? So we don't pile it up, okay? We're not a reservoir or a data lake. We move it around, okay? And there are fixtures and faucets and bathtubs and showers and spigots and things. We're not those, okay? Those are EHRs and HIEs and public health registries. We're just the plumbing that moves the data around. In fact, I didn't tell you this morning, we're moving almost 3 million protected health information messages daily. This chart is old. This goes back to March. We're up to about 21 million PHI messages per week. These are immunizations. These are admission, discharge, transfer notifications. These are CCDs at discharge with medication, reconciliations, we call those medrecs. It's a lot easier to say medrec. Syndromic surveillance, reportable diseases. We're getting into some new electronic case reporting for the CDC with chlamydia, gonorrhea, pertussis, salmonella, Zika, and 90 other conditions in a new pilot with the CDC. So all kinds of use cases of different kinds of PHI moving around in real time through our network, okay? And so I talked about this morning, but before MiHIN, you know, everybody tried to connect to everybody, and that's costly and it's inefficient. So MiHIN is sort of the hub and a spoken hub model. Everybody can connect once and send the information to us once, and we make sure that water, that PHI, goes through our plumbing, through our network, to where it needs to go. Okay, so I'm not going to repeat this slide, but basically we've spent almost 7 years connecting virtually every health information organization in the state of Michigan, either directly to MiHIN or to another network that then connects to MiHIN in our network of networks. So at this point in the evolution of health information networks, there are opportunities beyond merely moving data from point A to point B, such as public health reporting, where you just take an immunization and push it into the state immunization information system, or MICR. We have some MICR folks over here in the back. So the opportunities become intelligent routing of the information, and not only taking it from point A to point B, but also to points C, D, and E, to take, for example, the fact of an admission and share it with the entire care team, or the medrec at discharge and to share it with the entire care team, okay? And we could do more than that. We can start applying predictive models to the real-time information. I'm going to talk a lot about that, to try to help improve health outcomes and population health. So we share the information in real time, and with the predictive models, which we sort of view as like a traffic camera, I'm going to show you in a slide in just a moment, we can start looking for possible negative outcomes, and we can do something about those. So let's just think about the ethics of that. Is it ethical, and what are the ethics of looking ahead at predicting negative outcomes? So just briefly, an overview of predictive models. You can take statistics, machine learning, artificial intelligence, and using these techniques, you can forecast outcomes based on historical data, okay? For example, clinical research can be used to create computer models that predict specific outcomes like likelihood of diabetes or likelihood of colorectal cancer. There's an Israeli company that has some great models for predicting colorectal cancer and diabetes. And so you can also generate risk scores and associate risk scores with the PHI for a given person. And this can help you do advanced management of the health of a patient or a population. And so some examples of the value of predictive modeling, you can identify at-risk patients and implement early interventions. A pharmacist, for example, or a pharmaceutical company can forecast medication needs. Physicians can make more accurate diagnoses. And another example is that researchers can innovate without extensive population studies. So those are just a few examples of the value of predictive modeling. But let's look at how we could apply a predictive model to the real-time flow of information in a health information network. So imagine that the protective health information is an automobile or a vehicle traveling down the highway, the network, okay? And the passengers, the payload in the vehicle, that's your PHI, okay? And imagine the predictive model is like a traffic camera. And that traffic camera is trying to anticipate or watch for traffic jams or possible collisions or bad outcomes, okay? And if that traffic camera, that monitoring system, that predictive model can detect something in advance, it can set off an alarm and say, do something to prevent this jam, reroute some traffic, or do something to prevent this bad outcome, intervene, okay? And so that's our view on applying predictive modeling to the flow of the PHI through the MiHIN network. And we actually started piloting this with the University of Michigan with their knowledge grid team, and some of them are upstairs in the Connectathon right now presenting their results up there. And we started out with an opioid filter example, and we basically just had a simple classifier to identify a high-risk first-time opioid user. And once we detected that information, let's say in a med rec at discharge, we might append the classification information to the PHI message and then send it out to the providers listed by patient. And we can also do things like auto-enroll that patient in an education program, and we can send that information to multiple providers on the care team based on the patient-provider attributions. And we can also automatically update the statewide monitoring system. While we were in the middle of this pilot, something happened. I was sitting in my office one day, and our director of development rushed into my office, and he closed the door. And he said, Jeff, we have detected a problem. We were just doing some debug output, and we found that there's a very high rate of occurrence possible in some of the data of a thing called the triple threat, okay? And the triple threat is when a patient is on an opioid, a benzo like Xanax, and a muscle relaxant. And what happens if you take all three of those is that your lungs go into a condition called respiratory depression and you stop breathing, and that's it. And so when we looked at the data for about a month's worth of traffic, almost 3% of the patients had the triple threat at discharge. So what do you do with that? What were we required to do? Absolutely nothing. Michigan does not have a duty to inform law. Our data sharing agreements had no obligation on our part to do a thing. But what should we do? In an environment of Flint and indictments, we knew that we had to do something. I have a number of attorneys on speed dial on my cell phone, and I lit them up like Christmas trees, okay? And I started saying, Nate, Mike, Steve, Chanley, what do we do? Find an expert. So they found Larry Vernaglia, okay, who's with Foley, Lardner in Boston, and also on the board of Boston University, Larry? Boston?
School of Public Health.
School of Public Health, thank you. And he said, Jeff, there's a whole field of bioethics, but I don't know if it's ever been applied to health information exchange. And I said, Larry, we need an opinion fast, okay? So this was a situation we're faced with this accidental discovery of this knowledge that translate into the possibility of many lives and bad outcomes. So we got onto this as our priority number one. What should we do? We don't have to do anything here, folks, but there's something we should do. We just didn't know what. So, fast forward, we began a legal review and an ethical analysis immediately. And so we examined all of our legal agreements pertaining to data sharing and all of the laws, and we confirmed we don't have to do anything. But we started this exploration into this new area of the ethics of health information exchange. And we retained Larry and the folks at Foley to help navigate our analysis of our ethical obligations. So I'm going to hand it over to Larry now, and he's going to go through the principles of bioethics and how we applied them to this problem.
Thanks, Jeff. And I guess this is my second case study of the afternoon with you all. And I think that's terrific because like all good case studies, this isn't just to tell a good story. It's also to produce some generalizable lessons that others can learn from and apply in maybe similar situations. And that's the reason that Jeff wanted to share this project with you all. We hope it's helpful. The process that he's described where you first determined that there was no legal duty, I think is the right order of the process. Because law is what you must do. Ethics is what you should do, as I think you said before, and that was right. And so once the legal analysis ended, we started with an evaluation of what the ethical answer might be. How do we do that? Well, we conducted a literature review to determine whether there was any good rules of the road out there for this. I think I mentioned that I'm the chair of the health care industry team at our law firm with about 150 lawyers all over the country, and we hadn't seen anyone have to undergo such a process before. But you mentioned my role with the School of Public Health. I'm very familiar with medical ethics. I've been involved with ethics committees at many hospitals, and so there is a well-established set of rules around how to apply medical ethics in a clinical decision-making process. And so why couldn't we use a similar model here? But before we did, we wanted to survey the literature, and there was extremely limited information out there or thinking on this point. We also evaluated the MiHIN organizational documents. Corporations, to lawyers only perhaps, and Mitt Romney, are live beings. And the DNA of a corporation is its articles or its charter and its bylaws. So we evaluated those documents as well as policy documents to see if the values of the organization are explicitly out there. And if so, do they help us guide this analysis? Because ultimately, again, it was not a legal question, it was a values question. And so finding no established and agreed upon ethical framework for an exchange or a health information system in general, we applied the generally accepted principles of bioethics that have been well thought out in the industry for 25 or 30 years. We might call this the Georgetown mantra, for those of you who've played a little in the medical ethics space. But these 4 principles are a good organizing process. So autonomy, that is respecting the patient's individual choice, rights as an individual, right to make decisions, good or bad, is the first one. Non-maleficence, doing no harm, back from the Hippocratic Oath in a way. The third is the principle of beneficence, which is that when in doubt, make a good choice, do the right thing to help people. And finally, the principle of justice. How does it affect groups disproportionately harmful to one population or another? All of these are principles that have been well documented in application around clinical decision making. So the process that we used here was really one of a series of guided conversations and facilitated interviews with MiHIN and us as organizers for that. And we walked through each of these steps. The way to do so was, in our view, to walk through the potential benefits with respect to each of these 4 principles, and then ask ourselves, Jeff, are there any reasons not to be able to apply this in this particular case? I think if I take a step back, many people think about ethics, they say, well, there's an obvious answer to this one. And maybe some of you were thinking when you heard Jeff's presentation of the facts, well, there's an obvious answer. You obviously ought to tell someone about that. But that's not really the case when you think it through. And that's what makes ethics so interesting, is that the obvious knee-jerk answer sometimes isn't the one that you ultimately would go with. So when we thought about autonomy, for example, and this is an oversimplified version of the analysis that your board and leadership ultimately thought through, we asked, does the principle of autonomy play a role in the reaction to the K-Grid report? And I think that we thought about patients themselves have a right to be informed, and the principle of informed consent is the core output of the autonomy value system in Western medical ethics. And if patients weren't informed of their risk for injury with respect to consuming the 3 drugs in question or the 3 classes of drugs in question, then the support for personal autonomy would be enhanced there. Also, the patient has a right to make meaningful decisions about their care, the outcomes of the medications they take, what might be the interactions, and harmful interactions. And these patients, if they got this information, would be able to make more meaningful healthcare decisions. Providers themselves have a duty to inform patients of potential drug interactions in order to promote not just their best interests clinically, but also their individual rights. And so we ultimately concluded that there was a good argument to be made in the promotion of the individual rights and autonomy of the patient, that MiHIN could assist patients in making more informed personal decisions by enabling access to that information. But that wasn't the end of the story, because there are other countervailing concerns that worried us as we thought this through. The other side of autonomy is also the right to be left alone and to have private information remain private. And so one of the countervailing concerns that we evaluated was whether this would be viewed as an invasion of privacy by the patients. Would they think, holy cow, the government knows what I'm taking and they're tracking my medicines and they're following me to CVS? What else are they doing to me? And we considered whether patients might experience a sense of distress or anxiety as a result of the perception of invasion of their privacy. We also considered whether or not the patients would see this as a paternalistic invasion of their relationships with their physicians. Maybe their physicians made these choices, knew what drugs they were taking, and didn't want to have, again, some big brother or computer nerds, no offense, telling them what their doctors can and can't prescribe to them. So we thought these things through and allowed them to be part of the weighing process. The second principle that we evaluated was the principle of non-maleficence, not hurting people. And so as we thought these through, we considered what elements of non-maleficence might be promoted by taking action in this case. We haven't told them yet what action we were going to take, but we will. We're saving that to keep them here, aren't we? Exactly. So we said that there would be probably minimal risk of causing harm to patients, because you remember the principle is don't hurt patients. So if taking action was going to hurt patients, you shouldn't do that. So we thought there was minimal risk of actual harm from taking action, or certain actions at least, but that no action could be viewed as an omission and therefore an act of maleficence from a certain point of view, not legally, I must add, but at least potentially ethically. We thought that there was little effort or risk to the organization in choosing this act, and that we could also see that there were probably other constituencies than just the patients involved. So in our first ethical criteria, personal autonomy, we were principally only concerned about the impact to the patient, that individual and her decision-making authority, her autonomy. But with respect to non-maleficence, we were able to zoom out a little bit and think about other constituencies that might be harmed or helped. And these included the employees at MiHIN. The employees at MiHIN who came to Jeff, closed the door, lost sleep, felt worried, not just about their own safety or whether they're going to get indicted, but whether they had some moral obligation here that they were failing on, or were they going to become a bad person if they didn't take action. We had to consider whether the principle of non-maleficence would require us to take action to protect them or others who might be caused by the stress associated with the debugging exercise. But did non-maleficence always support a positive action here? Not always, and that's one of the benefits of an ethical analysis, that there's always two sides to an issue. And so we considered as well that taking action may cause people to lose faith in a health information exchange or the privacy and security of the data that passes through all that plumbing. And there's a lot of good that can be done that you've heard about over today, and of course many of you know, that comes along with having an integrated healthcare information system. If people lose faith in that and they don't trust it and they don't activate it, will there be harm resulting to them from that? Or will they no longer be able to access those benefits? And so we thought about the community benefits from good, meaningful sharing of data, and the risk to that as something that we had to worry about as potentially being in violation of the non-maleficence principle. A closely related flip side ethical principle here, and the third one for us, is the principle of beneficence, that is always acting in the best interests of others and not necessarily of yourself or your own organization. And so this one didn't take us very long to get through, did it, Jeff? We evaluated the facts that taking action may prevent real harm, including patient deaths, to 183 citizens or residents of Michigan, that we could relieve their conditions that would cause them suffering, harm, or death. We believed that taking action would allow patients and caregivers to make informed choices and promote their health. And with more information, they would be able to do things that would be in furtherance of their own salutary benefits and their health. And finally, we believed that it would prevent future harm and help others by spreading awareness of the triple threat, so that prescribers would be more mindful, patients and their families would be more mindful. So we thought we could help not only those 183 people, but maybe millions of people who would have access to it. As we evaluated what potential concerns there might be, again, we did worry about the risk of people losing faith in the system. And this is a real concern to me. I don't think that this is self-protective or covering of our butts. I think that this is a changing environment, and there are confidentiality and HIPAA freaks out there who think that everything should be protected and nothing should be shared, and they're missing opportunities to advance public health, population health, and a lot of other things that we really want to promote. And so we worried about the risk of future benefits and beneficial opportunities for patients and the community. And finally, we thought through whether the principle of justice might cause us to take action or not take action in this situation. And I think that there probably were some important thoughts here, and you mentioned Flint, and when you think about where the harm was distributed in Flint, it wasn't distributed to the richest and wealthiest and most well-represented members of our community. It was just the opposite. And so we wondered whether that might be a principle at risk here. Would the burdens and risks fall upon a disadvantaged population? Potentially those suffering from addiction or under treatment for addiction, or who are taking opioids, are certainly at a higher risk, and those people would be more intensely affected by not taking action. We thought that wealthier patients or higher SES patients might be in a better position to have this caught by somebody else, their primary care physician, their trusted physician or family member, their concierge medicine doctor who would never let this happen. Any of these other things might promote better protection of those patients as opposed to those at greater risk. And we did believe ultimately that this one principle was the hardest one, easiest one for me to say, the hardest one for MiHIN to apply, because it probably did invoke some public policy considerations above the scale of MiHIN.
Sure, trade with you. Justice was the hardest one for me to get my mind around, but I finally translated it to populations. But there were all these esoteric types of justice under the principles of bioethics. There was egalitarian justice and libertarian justice, and we just had the most trouble getting our minds around that. But once we translated to the population, I think we were able to get our arms around it. I have to explain this slide. So last month, Shreya and I were invited by Dr. Tom Traben in California to present at a bioinformatics conference in Carlsbad. And I have to say these folks in behavioral health are a lot more fun in their conferences because everybody was using cartoons. And Shreya and I were sitting in the back, and we didn't have any cartoons in our deck. And I said, Shreya, let's go to Google Images and just search on cartoon and bioethics. And this came up. And until that conference and the discovery of this cartoon on Google Images, we thought there were 4 principles of bioethics, the 4 that Larry just went through from the Georgetown mantra. Lo and behold, this cartoon implies that there are 3 additional principles of bioethics: fidelity, veracity, and say it, please.
Deontological.
Thank you. So I had to look that one up, right? And they border into sort of ethics and morals, okay? And so we did some additional legwork to prepare for today. And so we have a little bit of additional analysis based on this cartoon and the discovery of 3 additional principles that you're seeing for the first time today. Larry?
Sure, and I think that what we have here are some additional points that are really drill downs on some of those 4 core points. But for those of you who might choose to implement your own ethical analysis of a problem or a challenge, we thought it would be useful to share them with you today. So one of the others that we evaluated was the notion of fidelity, which is being loyal to promises that are made. And so how might that play out in the concept of reaction to the triple threat and what the K-grid showed, or the debugging exercise? And so there are important questions to ask as part of the legal analysis as well that I think this overlaps a little bit. So did the underlying privacy policies or disclosure policies have any promises that would be in play, either to not use information or to keep it absolutely private or to potentially report negative outcomes? I think the legal analysis probably concluded that was not the case. But the fidelity concept urges a organization to keep the promises if you make the promises. That sounds like good advice your mom might have given you. But I also think that it is closely associated with the bioethical principle of autonomy, which is that if a patient has made a choice because they accepted a promise, then that principle says you should honor that choice and the patient's decision, even if it's a bad one. I should have mentioned that when I said it before, is that one of the core notions of Western bioethics and autonomy is that patients are entitled to make bad choices. They just have to have information sufficient to know what they're getting themselves into and be competent. And that actually rolls itself into informed consent jurisprudence as well, but it's principal to the bioethics. So we said, all right, are there any promises that were made here, either implicit or explicit, to protect the public health or the patient's best interests, to protect the confidentiality of the information? And if you withheld that information, would the health information network be breaking a promise to provide quality data if it only provides part of the information? We thought about what concerns or what reasons not to take action might be supported by this fidelity notion, and assume that there were no promises made explicitly. Is there an implicit promise? Well, one of the implicit promises of a health information network or exchange is that the confidentiality of the information will be protected. Privacy and security are fundamental. They got to be like the golden rule of what you folks are trying to do. And so we said to ourselves, might disclosing data violate that implicit promise of confidentiality? The second, I should have walked through that. The second principle was the notion of veracity, which is described as a ethical obligation to be truthful. I do think that this one is also closely associated with autonomy of the individual, but also non-maleficence, because lying to someone is a harm, an evil. It might not cause them physical harm, but it's a dignitary injury to the individual, and therefore something that should be avoided. So with respect to this principle, as we thought it through, we said, how does veracity support taking action? And we thought that might include being honest about things that we learn, problems that we discover, and information that particularly might be harmful to a patient if they didn't receive it. We thought that omission of relevant information might be seen as a lie. Sometimes the information you don't share is when omitted, makes the rest of the statement inaccurate. And finally, we thought that silence might be viewed as misleading a patient into believing that there were no health risks. And so these supported taking action in one form or another. What concerns might be raised under the principle of veracity by taking action? And again, I think that many of these concerns are similar in that this one is, someone might take the position that MiHIN had been dishonest or dishonorable in using predictive modeling without explicit informing of entities or patients about its use, and therefore veracity might be limited. So as you thought these through, and we continued to think about what the cartoon told us, we then dealt with this final principle, which I think is really just a way of looking at data. Do you want to talk about that, or?
Yeah, I first had to learn how to pronounce deontological. Is this working? Yeah. And, basically it just means follow the rules, okay? And that raised another question. What are the rules? And who makes them? And we're going to talk about that and give you a thought exercise in just a moment. But, following invented rules could violate our inherent sense of what is right or wrong, okay? Especially if the rule makers made rules with bad intent, or rules that just don't comport with our sense of right or wrong. We did not believe that disclosure would violate rules because rules have not accounted for this scenario yet. No one has made rules around this type of situation that we could find, and we Googled a lot. So we also viewed that our response here could be sort of like case law, right? We could be setting a precedent that establishes a rule that other organizations might follow in similar predicaments. Larry, do you want to talk about the concerns here?
Well, sure, and I think that that when the question is follow the rules, it leads us back again to our legal analysis. But in this one, we thought that using a well-established set of bioethical principles, medical ethical principles, would allow us to say that we had applied the best set of rules that we could find for solving this kind of a problem, and we did so in a systematic, thoughtful, non-biased way that didn't take financial interests or personal interests of staff or management into account, but rather looked at a variety of constituencies, including the patients. So we felt comfortable that we had established and set up a set of rules, best as there were at the time. But maybe we need to invent a new set of rules.
Which is our next topic. So at the time of this discovery of the debug output, we could not find the rules. The Georgetown mantra was the closest thing we could find for guidance. So now we have the natural questions that are begged by this situation. What should the rules be? Who should make the rules? And is there a framework that exists that we can refer to for situations like this for further analysis? So we Googled, and we Googled some more, and then we started having creative conversations. And we remembered in our youth a book called I, Robot by Isaac Asimov. I see a couple of smiles. Some of you read it, with a flashlight under your bed covers at night, and you imagined a future of robots following the 4 laws that were a part of science fiction at that time. We have a lot of robots now. But the first rule was a robot may not harm humanity or by inaction allow humanity to come to harm. The second rule was that a robot may not injure a human being or, through inaction, allow a human being to come to harm except when required to do so in order to prevent greater harm to humanity itself. I'm going to pause right there, and you can start seeing some of these themes of justice and autonomy and non-maleficence starting to emerge from this framework from science fiction of years ago. The third law, and originally there were just 3 laws in the first book, right, was a robot must obey any orders given to it by human beings except where such orders would conflict with the first law or cause greater harm to humanity itself. And that's kind of where the first book, I, Robot, ended. And somebody can help me with the name of the book where the 4th law was invented. But that was that a robot must protect its own existence as long as such protection does not conflict with the first or second law or cause greater harm to humanity itself. And we said, well, this is still quite a bit of science fiction, but is there a way to take the 4 principles of bioethics and to sort of try to spread those out over this framework to see if we could start extracting some kind of a basis for a set of rules? So we did start sort of mapping the 4 principles. Larry, do you want to talk a little bit about this?
Sure. I think that that what we're trying to say is that the analogy here is that the robot is the network, and that network isn't just a tool, but it maybe has some real life existence outside of just the ability of the tool to be done to do things at the instructions of others. And so what does not harming humanity mean? It probably has more to do with population health than initially meets the eye. And I think that the order we have here is the first rule might have actually been the 4th rule in the chronology of the books. So that the original writing of the rules was don't harm a human being. So the technology in this principle should say that the health information exchange or the health IT package can't hurt a patient. It was only after thinking through 2, 3, and 4 as the original 3 rules that the writer came back and said something's bigger than just that one individual patient behind us, but it's also the whole population, all of humanity. And so as we thought through the debugging exercise, we were worried about those 183 patients, all of those impacted by Rule 2 potentially. But then we said all of the residents of Michigan, that might also be the application of the don't harm humanity.
So this is just sort of a work in progress. We just actually started, I would say, exploring this as a framework to the problem of when you apply machine intelligence during real-time exchanges of health information, where we have an outcome of heretofore unknowable knowledge that could then now be known and improve outcomes or prevent harm. What are the rules? And so we had, the attorneys and the legal assistants and other folks searching far and wide for existing laws, and we came up empty-handed. So the challenge for you today is to take our thought process so far of applying the bioethical principles to an existing framework, albeit from science fiction, to say, what are the rules and who should make the rules? And that's a take-home exercise. It's not answerable today, or if you have the answer, please raise your hand, okay? We're not finished with this framework. We're not finished with our analysis. We're not finished thinking this through. We're at the beginning of this journey.
And here's how we finalize it. So we take the four principles and apply it here in health IT, and say that an exchange must share data except when doing so would harm the privacy of a person or population in an unacceptable fashion, that the exchange may not cause injury to a person. Oh, thank you. I'm not used to this kind of, this is high tech.
We're learning as we go.
This is good. Yes, we are. That's right. That the exchange may not, through inaction, allow a person to come to harm. And finally, this is where we get our creativity and our original thought, and go through, I think, that deliberative and iterative process that we did to ultimately come to a decision to take action. And do you want to conclude by talking about what we decided to do with this information?
So after all of the analysis was said and done, the conclusion was that we had an ethical obligation based on the merits of the four principles to inform the organization, not the individuals, because we're not clinicians. We're a health information network. We're plumbers, okay? We're operating a network, a plumbing network, moving data around. We're not responsible for making clinical decisions or conclusions from that data. However, based on the discovery of the debug output, we had an ethical obligation to inform the health system, which we did. And then from that point forward, the responsibility on how to act upon the information was in their hands.
So we evaluated each of the possible action steps that could have been taken following this, and were we the right people to do it? Did we have the information, the technology, or the sophistication to? Might we have been wrong? Reaching out to the patient had all kinds of other risks that would have been inconsistent with the four principles that we walked through, whereas bringing it to a medical director or a real clinician who had the ability to act on that in an intelligent way, we thought was much more responsible.
And a sub-theme, I think, Larry, that we touched on, but going back to this morning when we talked about the incredible trust framework that many of you attorneys in the audience and organizations represented here help us build a statewide trust fabric. And, we talked about TEFCA. What's the T in TEFCA? It's trust, okay? And the sub-theme is that we were paranoid, truly paranoid, about taking some action that would pierce or rip that trust fabric and violate the trust that we have built over years with all of you to have this statewide network that can improve health outcomes. So if we took the wrong action and tore that fabric of trust, we could conceivably have irreparable harm to the statewide health information network. So that was foremost in our thinking at all times during this examination and our actions.
We have a few minutes for questions if we want to, if anyone has any. Some down front.
Bring a microphone down, please.
Thank you. For a clarifying point, the information that told you about the triple threat, was it all from the same source, or were you combining information from different sources? The
information was primarily from medication reconciliation information at discharge. And that's really the only place where you can find that kind of information. You can't find it from prescriptions, for example, from SureScripts or that type of information. You can only get it, from something like a CCD at discharge. And that's where we were getting it.
Because I wonder if that would make a difference, right, for your obligations or your ability to give the information back to the source. It's one thing if you have a relationship, perhaps through a BAA or a QSOA with a particular entity that's giving you the information. You can report back to them and factually give that information. But if you're taking information from multiple sources, it's going to depend on your relationship with those sources to then disclose the information you obtained from them to somebody else. So that, I wonder if it would affect your analysis. But the other question I have is whether, based on this, have you considered changing your disclosures in your agreements as to the potential for you to make other uses of the information you've obtained?
We've had some early discussions, but we haven't taken action on that. We are in the process of sort of TEFCA-izing our legal agreements because, as you heard this morning, when the common agreement and the minimal terms and conditions come out, we have 12 months to implement that. So we're sort of putting the hooks into our legal stack, and we're making them electronic and easier to modify. And that's a part of that discussion, but we have not, completed that. On your first question, the multi-source sort of question, it really sort of depends on the predictive model and what you're looking at. I mean, predictive models can look at different sources of information. I mentioned those Israeli models for diabetes and colorectal cancer. They do look at different sources like labs and other clinical information. And so it really depends on the model, as what sources you're looking for, what you're trying to do with the predictive model. In this case, with the opioid filter example, all three things we were looking for were in the CCD at discharge. Other questions? Looks like there's one back here.
Thank you for the incredibly thoughtful analysis. Wow. And the great presentation. That was fantastic. So if I heard you correctly, you informed the health organization. I wonder what kind of discussion you had about informing the physician, given that, if I understand correctly, this was generated by a discharge, which would imply that there was an attending physician. And one of my concerns in notifying an organization versus the physician is that it could get lost in translation. In other words, would it ultimately make it back to that physician? And then kind of another side of that question is, was there any sense of obligation in this case to the clinician who was working with the patient? So kind of two in one.
Thank you, Scott, and thanks for the kind words. I recall having that conversation. We did talk about that, and we do, have the active care relationship service, so we know the relationships, the attributions between the patient and, well, our computers know, okay? We, human beings at MiHIN, don't know the attributions between patients and providers, but the software services know. And so we had the conversation, should we notify the physicians? But we don't have a relationship with the physicians. Our legal relationship is with the organization that signed our data sharing agreements. So we had to stay within our trust fabric, but we did have the conversation. Larry, would you like to add to that?
Yeah, another concern would be if you take action and it's incomplete or ineffective, then you haven't accomplished your goals. What if you got to the wrong physician? What if you got to the physician and she didn't take action? What if there were multiple physicians? Also, the labor associated with that would have taken time. And speed was essential here because we were very concerned that people might die while we were processing this. And so what we didn't mention in our remarks a minute ago, one of the things we were thinking about as we processed what actions to take would be efficacy, speed, and the ability to prevent the harms and risks that we had processed as well.
Speaking of speed, I wondered, one, how long it took to go through that analysis from the time that the person walked in your door and shut it, to the time that you made that decision? And two, in between there, because I know that you just said that speed was one of those factors that was really weighing on you, was there anything that you did in the interim while you were waiting to make that decision?
The short answer is it took too long. I wanted to act right away. I wanted to act immediately. I mean, it was one of those things, it's like, I've got to do something now, right? So any elapse of time was too long. But Larry knows that we moved as fast as humanly possible, but it was a complex situation. So it did take a number of days for us to form the opinion, and we also had to inform our executive management and board of directors, and we had to do everything the right way, okay? And that doesn't happen instantly. It's not like, well, let me just pick up. It wasn't like speed dialing the attorneys. It wasn't like that. I wish it could have been. It felt like it was forever, but I don't think we could have moved any faster.
It probably took about 10 days from start to finish, as I recall. And you took action rapidly upon conclusion of the diligence. So among the steps that we didn't mention is we also consulted with some of the nation's leading bioethicists with whom we have relationships to ask their feedback on the process, as well as to make sure that we weren't missing anything.
I do recall that I was very much a pest of the people I was waiting for, at various stages. The gates, I mean, I was kicking butts. I really wanted to move this. I felt a sense of responsibility because I had this knowledge, right? It's like ringing a bell. You can't unring a bell, right? And so you have this knowledge and you can't get rid of it. You can't stop thinking about it. And so I just don't know what we could have done to move any faster, but it always felt slow, right? It's one of those things that you want instant results, but you can't because it's so complicated.
Would have been a little longer if we had to go through an IRB or something, I suppose, or an ethics committee.
It would have been a lot longer. These are great questions.
Yes, sure are.
Hi, for disclosure, I work with Jeff as his lawyer, and I'm a colleague of Larry's, but I did not work on this project. And I have a comment, and you can comment on it if you'd like. It's not really a question, but hearkening to Jeff's comments on the takeaway homework about the challenge of determining the rules, I think it's really important when we talk about artificial intelligence is that the rules are principles. Like you said, they're principles. And the difficulty lies in when you get down to choices that really are philosophical, that we studied in college, maybe graduate school, about, well, how many people should be harmed or not harmed. I'll use an example that I use sometimes. I'll take it out of healthcare so as not to offend anyone, but in autonomous cars, this comes up, and you have the rules that set how the car will react. Well, what happens when you're driving down a road and a car is coming at you and there's people on the sidewalk? So individuals have to make those decisions to program the AI, and it's very difficult. It's in concept, and I'm a big proponent, and I'll be speaking in a minute, a big proponent of AI and machine learning, but I just want to reiterate for the group, and if you have any comments on it, Jeff or Larry, please do, but the challenges of the programming and in making those decisions, that it's, the software will make the decisions based on the human input. I'm just wondering if you ran into those challenges in that particular project or otherwise.
So, based on your comment, sort of what pops into my mind is one of the examples for the deontological consideration, which is follow the rules. And the example, one of the first ones I read when I was trying to understand that principle was you have a software programmer, and He knows there's some computer system that's going to launch some, terrible weapon like a nuclear weapon and destroy a lot of people, and he knows how to hack into that system and stop it. But his rule is not to hack into systems that are not, where he doesn't have legitimate access, right? So which rule does he follow? His own, personal credo of don't hack into systems he's not allowed to access, or sort of justice and non-maleficence, right? And stop the launch, okay? These aren't easy questions, right? I mean, it seems obvious, stop the launch, right? Save the people. Okay, I don't know that I have a concrete answer. In this situation, we looked at the principles and the situation we were in total, and tried to foresee any side effects of any decisions that we made. And so it's never as simple as the example of the the hacker and the nuclear launch. It's never that simple, right? It's just there's so many moving parts and so many considerations. And I think you just have to assess the situation when you're in it. And if we can have a framework with rules and guidelines beyond the principles of ethics, great. It's sort of my hope that the legal community will eventually evolve a set of rules that are clear, and that, if this occurs, this is what you do. I don't think that is a near-term evolution, but I look forward to it one day. I hope I've given you a nice reaction to your comment. Larry?
I might add to that as well by saying that I can see sort of two paths for responding to your question, and the first one is there a way for some of these technologies, particularly AI or aggregation of big data, to sort of roll over the patients, to continue your automotive metaphor? And the easiest example of that, I think, is in coverage criteria, which are drawn from big data, and whether screening will be executed in one population or another. And when there's no money for things, effectively you have made the decision, regardless of what the physician's clinical decision making will be. So I do think that's a risk that we've been facing for some time. It's made more stark by machines because people can then come to rely on them, which leads to my second point, which is these technological advances to enhance clinical decision making. And this is not new, by the way. We have had clinical practice guidelines for a really long time, but they used to be written on colored paper in 3-ring binders, and there were implications to providers who didn't follow the clinical practice guideline. Here, though, they look more authoritative when they come out on the computer with a instruction of what might happen if you don't follow it. And the challenge that we have is, unlike in the context of the coverage potentially, is how do we use these tools to enable and enhance clinical decision-making by physicians, to allow them to maintain their clinical independence while they're making choices using these tools, and not make them the drones sitting behind the wheel without turning it themselves.
I just wondered how you discovered this interaction, because you've mentioned that you weren't clinical, and I'm not aware of MiHIN providing analytics. And does that make you a different type of entity? That fact that you were analyzing the information that you hold in that way?
So it was purely software debugging. We were in a pilot, under a pilot agreement, and the technical staff were trying to verify that the predictive model was producing accurate results based on the input data. Simple debugging. And no one was trying to analyze data. They were just trying to make sure the numbers added up, right? Did the model find this, this, and this, and did the numbers add up? And in fact, when we first were debugging, the numbers were double. So it was counting things twice. And that's normal in the course of software development and debugging. When you have an error, things are off by 1, or you count things twice, Okay, those are very typical software errors that you find during debugging. So they were really just trying to verify the model worked and the results were accurate. No one in their wildest imagination thought that 2.9% of the CCDs that were examined by the model would have the triple threat. So that was the accidental discovery. We weren't looking for what is the percentage. We were looking at how many are there, just count it and check it, right? Whatever it is, that's what it is. But when it came out so high, that's when the jaws dropped and the doors closed and the speed dials started happening. Does that help with your question? I have lain awake thinking of that. And what if it were one, right? That's a great question. Would you like to come up here? My seat's getting very hot right now. I should go back to the fire connect-a-thon. There were a couple of others back here. Yeah, right at this table, and then Scott again. Go ahead with Scott.
So Jeff, it feels like this was a ad hoc one-time event, but now you've got visibility into some opportunity to help out in the healthcare community. So what's next?
So you're absolutely right. I mean, this was a one-off pilot with the first, digital knowledge object from the knowledge grid. But I mean, the whole idea with the knowledge grid is you could have a whole library of these predictive models. And you could check these out and attach these cameras to your network, right, and watch the data. And so we've opened this whole new big can of worms. Wow, nobody thought of this, right? What happens now when we start having these cameras watching, and it's like, oh, there's going to be a crash here, there's going to be a jam there. What are the rules? Just nobody's been here before. We went with the folks from Michigan Medicine, or U of M, Dr. Alan Flynn, who's up in the Connect-a-thon, to brief Dr. Donald Rucker, the national coordinator in Washington, and several staff from the ONC and HHS on March 15th, and we went through this. And if you've heard Dr. Rucker speak at any national events, you know he's very big into artificial intelligence. And so he actually wanted to see the code of this knowledge object. He's a former programmer, right? I mean, he wrote an EHR, okay? And he was drilling down into the code of this knowledge object that looks at the triple threat. And so we had a lot of conversations. We had some deputy secretaries of HHS there. We're in dialogue, okay? I mean, there's this whole new world that's opened up now in the whole learning health systems arena enabled by reusable, computable biomedical knowledge. Now we can do this. Great. We can do this. What do we do with it? I don't have those answers. But we're going to continue doing more pilots. We're going to continue the discovery process. We'll eventually get there. We'll eventually have a framework. We'll eventually have a deontology with a set of rules. But we're at the beginning of this journey. And we could use help. Hopefully there will be some folks that are interested in these problems who will connect after this summit. You can reach out to Larry and I. We're in eager pursuit of additional thoughts and opinions because, this is not a paid project to explore the bioethics. It's something we should do.
If there's time for one more, and maybe there isn't enough time to answer this right now, but I think this excellent discussion and the thoughtfulness that's been invested so far causes me to wonder about the transparency of the algorithms underlying artificial intelligence moving forward. In other words, if they remain proprietary and inaccessible to be evaluated, kind of like the person who wanted to see the code, what are the implications there for transparency around IP and the algorithms in assessing these important ethical questions?
So there was a convening of the Learning Health Systems folks with Chuck Friedman's group in Ann Arbor a few months ago, And those very questions were raised. How much of the predictive model can be exposed and validated and so forth, is particularly when you have proprietary technology involved. And there were some analogies from other industries that were raised. For example, automotive and some other industries where there are large digital libraries of knowledge that are published. And I would say that that work is also just beginning in terms of defining, what are, how does the library of digital knowledge objects work? And how is that knowledge made transparent? What's published, what's proprietary? Those are all open questions that are actively being explored. You're asking the right questions. I don't have those answers either, but I'm hearing a lot of dialogue around those very topics. Larry, do you want to add to that?
No, that was good. Nothing to add.
I think Aaron has a question over here.
Thanks. Yeah, so first, I'd like to say thank you. I think you guys drew the right conclusion. I turned to Jim while you were going through that and said, we didn't get notified, did we? But I think you made the right decision in notifying. So in regards to some of the things that are happening in healthcare, though, so one of the measures of meaningful use that's coming, the EP must use clinically relevant information from CHRT, excuse me, let me find it. Providers may not prohibit patients from using any application, including third-party applications, which meet the technical specifications of the API, including the security requirements of the API. And basically, what that's getting at is patients allowed to connect to EHRs of health systems to extract their patient information into portals, right? So in that regard, we're going to be amplifying the number of third parties with access to this data that can do this sort of analysis exponentially. And I think when you look at it in terms of the actors that may be at play here, the Amazons, the Googles, the Microsofts, I think it opens up a whole different lens for what we're looking at here. And not just a triple threat in terms of something that may be fatal for the patient, but are they on the right drug? Could I sell them a better drug? Things that start to interfere with that patient-provider relationship. And I think we've got to be careful in not crossing that line, and also be careful with the industry trend of the number of people that have access to this data and are able to do analysis on that data.
Thanks, Aaron. Well, that's a big one. The first thing that came to mind is I think a part of that was written, I could be wrong, but I think a part of it was written with the intention of a push-type technology like Blue Button Plus, where you sort of push the information out through the API to the consumer app, okay? I think that might have been part of the intent. I don't know if it's intended to be like a two-way bi-directional thing, but if it is two-way bi-directional communications between the EHR and any consumer app, then you suddenly have the medical device security problem on steroids, right? I mean, you have all these attack surfaces from all these apps that are going to be coming out through the Apple Care Kit and all the developer kits that are out there now for building consumer healthcare apps, and that is a whole new set of risks. In terms of will these consumer apps have predictive models? That might be a long time in coming. I mean, I think mainly what consumers want to do now is access and manage their information, and to sort of mediate sort of the covered entity to non-covered entity barrier that the Caring Alliance is looking at, so that as a consumer, I can get my health information from my PCP or an EHR into my app. Then I can decide where else I want to share it, even with non-covered entities, right? And so that sort of bridges that CE to non-CE gap. that exists today. But I would have to look behind that rule and see what is actually behind it. If you would share that with me, I'd be happy to look further into it.
I'd add that clinicians, you better fasten your seatbelts, because if you thought that direct-to-consumer advertising for pharmaceuticals was a pain in the neck for your practice, wait till you get a load of the direct-to-consumer diagnostics and predictive modeling that I'm convinced is going to be a lot sooner than you, perhaps, because I think it's easy to do and people want it, and everyone's looking. People turn to Google for their medical advice these days, but Google armed with health information from your own EHR as well as a drop of blood is going to be making a lot of little iPhone doctors out there. So I'm glad I'm not a physician in the 21st century.
Thank you so much. I just got lit up here that we're a few minutes over. Thank you so much for sticking around and for all the great questions.